We now come to assessment of Janelle's hearing. And there's really 2 or 3 phases to this, and the first is just a basic crude hearing test. So what we're going to do first of all, Janelle, I'm just going to block your left ear, and I'm going to whisper about 30 to 60 centimetres from you, and I want you to tell me what I say. Okay, I'm going to start off with a very light whisper with a fully exhaled breath. I'm then going to work up to a progressively louder whisper until you say, yeah, and you tell me what I actually said. Let's give it a go. 9, 2, 3, 4. Can you hear that?
Yeah.
What did I say?
9, 2, 3, 4.
Excellent. Right. Okay, I'll come round to the other ear and we'll do the same thing. And I'm covering my mouth just in case you do attempt to lip read, and of course, looking straight ahead, that's really not possible. 5, 3, 7, 9.
Yes, 5, 3, 7, 9.
Excellent. Janelle actually has normal hearing, and of course this is only a very crude test for hearing. If she did have a hearing problem on one side, or unilateral hearing loss, we'd next need to determine whether it's a sensory nerve hearing loss or a conductive hearing loss. In order to do that, the first test we use a tuning fork, and the tuning fork we use is either a 512 or 1024 Hertz tuning fork. This first test is called the Weber test, or the German pronunciation, the Weber test. And it simply involves vibrating the tuning fork, placing the tuning fork on Janelle's forehead. Janelle, I want you to tell me which side the sound has the loudest sound. What did you think? Let's just do it again.
This side.
Well, it's interesting that Janelle actually identified the right side. We actually established that both sides were equal. Normally, the Weber test produces sound differentiation equal on both sides. Shall we just try that again? I'll put it in the middle of your forehead this time. Which side was loudest then?
I think it was equal.
About equal.
Yeah.
Normally we would expect it to be about equal, particularly when we've established that just on crude hearing, that hearing is equal on both sides. The Weber test then produces a more pronounced sound when we put the vibrating tuning fork on the centre of the forehead or the centre of the scalp. In people that have got a conductive hearing loss, the sound is actually loudest on the affected side. If it's a sensorineural hearing loss, the hearing is loudest on the good side. One other way of establishing whether it's a conductive deafness or a sensorineural deafness is to, first of all, place the tuning fork on the patient's mastoid process behind the ear. Janelle, I want you to tell me when you can no longer hear the tuning fork vibrating. Now, as I put it to your ear, can you hear it again?
Yeah.
You can. Because Janelle could actually hear the tuning fork, once we'd taken the tuning fork off her mastoid process, this indicated that she has normal hearing on the right-hand side. If she had a conductive deafness, we would find that as soon as we take the tuning fork off the mastoid process, she can't hear the tuning fork vibrating through air, indicating that bone conduction is superior to air conduction. The patient with a sensorineural hearing loss, we would actually have normal air conduction, the same as in a normal ear, although of course not as pronounced because of the actual nerve damage. This second test is called the Rinne test. So we can use both the Weber and the Rinne test to confirm the presence of conductive deafness and to differentiate it from a sensorineural deafness. We now go on to examination of the external ear and then the internal ear using the oroscope. You'll notice in this section of the video I've donned gloves for the reason that from here on in, when we examine the ear, later the mouth and nose, we're touching a body cavity and therefore the possibility of touching body fluids. So I do recommend that gloves are worn for your own protection. Let's first of all focus on the external ear. If we have a look at Janelle's external ear, we're looking for external deformities of the auricle and the tragus. We'll also, before we start an internal examination, also just pull on the auricle and press on the tragus. Now, if there's any otitis externa, Janelle will notice pain as we do that. Does that cause pain, Janelle?
No.
If there's any otitis media, if we press just around the mastoid process of the temporal bone, she'd notice discomfort. Is that uncomfortable?
No.
To examine Janelle's right ear, I'm going to be using the oroscope in my right hand, and what I'm going to do is pull the ear or the auricle backwards, slightly outwards and upwards. Then inserting the larger speculum that will comfortably fit in Janelle's ear into the external canal, and under direct lighting and using my right hand for proprioception, so that way if Janelle moves during the examination, the speculum will go with her. And we're looking in the external canal for signs of inflammation, wax, foreign bodies, also the eardrum for signs of holes, inflammation, or bulging forward, demonstrating signs of otitis media. Also looking at parts of the ossicles that are visual through the eardrum. And Janelle's internal ear looks completely normal, with the gloves putting aside the used speculum. Structures associated with the drum and visible with the oroscope is shown in this slide of a normal eardrum. This slide shows perforation of the drum. Perforations are holes in the eardrum that usually result from purulent infections of the middle ear. This slide shows serous effusions. These are usually caused by viral upper respiratory tract infections or by sudden changes in atmospheric pressure as caused by flying or diving. The eustachian tube cannot equalise the air pressure in the middle ear with that of the outside air. Air is partly or completely absorbed from the middle ear into the bloodstream, and serous fluid accumulates because of the vacuum effect. Symptoms include fullness, mild conduction hearing loss, and perhaps some pain. A fluid level, a line between air and fluid, can be seen in this slide. The next slide shows acute otitis media with purulent effusion. The drum is reddened by dilated blood vessels and has begun to bulge. Landmarks become gradually more obscure as the drum bulges forward.